Hello, this is Stephen Holloway. Today we're going to be discussing urinary tract infectious disorders. This is part of Nursing 202, Module E. Urinary tract infections are the most common healthcare-acquired infection. About 7 million healthcare visits occur each year because of urinary tract infections, which ends up being about 1 million hospitalizations. The cost annually for the United States is about $1.6 billion a year, and that's just looking at the adults. The big thing is that catheter-associated urinary tract infections are the most common hospital-acquired infections, accounting for 30 to 40% of infections in hospitals each year. Now, we do know that urinary tract infections and infections of the kidneys are most common, especially in younger women. Manifestations of a urinary tract infection account for all of those $7 million, 7 million healthcare visits. This information all comes from the Center for Disease Control in Atlanta. The infectious disorders we're going to be looking at are going to be urethritis, cystitis. We're not going to talk about prostatitis at this time, as we talked about prostatitis as part of the men's health area. We're also going to be talking about pyelonephritis as part of it. The site of the infection is really important to know along with the specific type of bacteria, because that's going to determine the treatment. And there are several risk factors associated with the occurrence of urinary tract infections. You can see Table 69.1 in your IGI, which will give you some of those infectious processes. Now we're going to talk about cystitis, some of the pathophysiology and the etiology of cystitis. Basically, cystitis is an inflammation of the bladder. That inflammation can be caused by an infectious process, either with bacterial, fungal, viral, or parasitic agents. It can be non-infectious, caused by drugs, radiation, or immunological type processes, as seen with systemic lupus erythematosus. Then there's another process which is called interstitial cystitis, which is related to neither. It's more a really unknown cause, but it is rare. When we look at the pathophysiology, as we talked about, cystitis is an inflammation of the bladder. These infectious agents, which is usually mostly bacteria, move up the urinary tract from the external urethra to the bladder. Less common spread of infection through the blood and lymph can occur, but most of the time when we're looking at cystitis, it is coming from the urethra up. When we look at infectious cystitis, the most common organism moved from the intestinal tract and is E. coli. It accounts for about 90% of the urinary tract infections. Little terminology: the presence of bacteria in the urine is called bacteria. And it can occur with any urologic infection, whether it be cystitis or urethritis or even pyelonephritis as we move up the things. When bacteria are present without symptoms of infection, it's called colonization. Colonization is an asymptomatic bacteria, and it's more common in older adults. Most of the times, this problem doesn't appear to progress to an acute infection or kidney impairment unless the patient has some pathological problems. Then it will require treatment. Clinical manifestations of cystitis include frequency, urgency, dysuria, feeling of incomplete bladder emptying, low back pain. And for some of the older adults, you may see some more special type things. The older adults, you remember many times when they get a urinary tract infection, you'll see a lot of confusion, very much some changes in altered mental status as we look at it. Some of the other things that you don't see on your screen, which are listed in Table 69.3, may be low back pain, nocturia, incontinence, pyuria, bacteriuria, urinary retention, suprapubic tenderness or fullness. Rare clinical manifestations of cystitis will be fever, chills, nausea and vomiting, malaise, and flank pain. Those tend to be more when we start looking at pyelonephritis. In the older adults, again, we may see that very sudden onset of altered mental status, worsening incontinence, fever, tachycardia, hypotension, which all could be signs of urosepsis, which is a bigger concern with our older population as we look at it. They may also have loss of appetite, nocturia, and dysuria as part of the process. So how do we diagnose a urinary tract infection? Typically, we're going to get a urinalysis. The urinalysis will show a positive leukoesterase and positive nitrates in 68 to 88% of the time. And that's 68 to 88 sensitive in the diagnosis of a urinary tract infection. Also, the presence of 100,000 colonies per milliliter, or the presence of 3 or more white blood cells, pyuria, with white blood cells indicates infections. Now, unless you have a complicated issue with a cystitis, or someone that has had frequent problems, or some other type of urinary tract dysfunction, a culture sensitivity is not always necessary. Do remember, though, if we do need to do a urine for culture sensitivity, that needs to be done with a clean catch midstream specimen. If your patient cannot get a clean catch midstream, many times we'll have to slide a catheter in to collect the urine. For routine urinalysis, 10 milliliters of urine is needed. Smaller quantities are needed for culture and sensitivity. Also know that basically when they look at the urine is typically done as a dipstick, which will tell you the glucoesterase and the nitrates, and whether there are red blood cells or white blood cells present. To give us the count on white blood cells, bacteria, those type things, a microscopic view of the urine must be done. Do know that if the urine comes back, the microscopic shows more than 20 epithelial cells per high-powered field, that suggests contamination, that this is not a good urine and would not be a good urine to do a culture and sensitivity on. If we have someone that has had recurrent urinary tract infections, greater than 3 to 4 per year, we may send them for further testing because there's something going on causing that issue. So one of the things that we would do is send them to a urologist. Urologist many times is going to do a cystoscopy to look and see if there's some physiological or pathological problem or an anatomical problem with the urethra, the bladders, or the ureters, to see if there's urinary reflux that might be causing some of these problems. Now, if we do have someone that's also having recurrent urinary tract infections, we do need to provide them with some education on how to prevent those. You'll see that in chart 69.2 in your IGI, and we'll talk about that a little bit more as we talk about treatment for those type processes. Well, treatment basically are typically antibiotics. Chart 69.4 gives you a list of the major type antibiotics and medications used in treating cystitis. Antibiotic therapy for cystitis has changed significantly over the years. Typically today it's a 3 to 5 day treatment for cystitis. Drug of choice in most cases is Bactrim DS, which can be taken twice a day for 3 days. Remember, with Bactrim, you need to make sure they take a full 8 ounces of water, and you advise the patient to use sunscreen and avoid being outdoors while they're taking the medication. Review that chart, look at those. Others that you may see are antispasmodics, such as pyridium, and some analgesics as well. Comfort measures can be done. Your book talks about sitz baths. That can be done for short periods of time. Be careful with sitz baths, because even with sitz baths, you can get more bacteria from the anal region into the urethra for females. So that's a very controversial type thing for that. Nutrition, make sure they're drinking plenty of fluids during that time, and needing a well-balanced diet to make sure they're getting the nutrition they need to rebuild that. Some of the things that you'll also see talked about, and I'm sure you've heard about, is cranberry juice. Cranberry juice does appear to decrease the ability of bacteria to adhere to the epithelial lining of the urinary tract. thereby decreasing the incidence of symptomatic UTIs in some patients. But really, it's used more of a preventative type thing. Cranberry juice must be consumed for 3 to 4 weeks to be effective, and the efficacy of cranberry tablets has not been established. Your book talks about drinking at least 50 milliliters of concentrated cranberry juice daily as that process to kind of prevent urinary tract infections. Look at the table to see, simple things such as teaching young girls how to wipe from front to back and not back to front to prevent the colonization of bacteria into the urethra area. The big thing I want you to focus on is, as most of you will be working within hospitals, the biggest problems we talked about earlier is the catheter-related cystitis or infections. Again, as we move forward with the Affordable Care Act, if we have a patient that comes in that does not have a urinary tract infection and develops a urinary tract infection as a part of the process, especially of getting a catheter, then the hospital is going to have to eat the cost of that patient being in the hospital longer and the treatment of that process. You do know that basically nurses now there are protocols out there where nurses are assessing the necessity of that patient having the catheter and can, at any point in time, if the patient meets certain criteria, remove that catheter from the patient. Some of the other things that they talk about in Table 69.1, using the smallest catheter possible, 14 to 18 French, and they're saying with a 5 milliliter balloon. Again, guys, we have taught you how to use sterile technique in putting in a catheter. Please be diligent as you put in the catheter. It's very, very important not to introduce any type of pathogens into the urinary tract. Maintain a closed system. There's no reason to break that system open at any point in time. You need to try to avoid routine catheter irrigations if possible. And this is one that bothers me a good bit. Keep that urine collection bag below the level of the bladder at all times. Elevating that collection bag above the bladder causes reflux of pathogens from that bag into the urinary tract. And we know that many times that bag will drop off the bed, get into the floor. When we open it up to drain it, we may not use as good a technique as we should in trying to protect it from getting infected. So please, please do not do that. Good catheter care is very necessary. That should be done daily for these patients. There are new catheters that have special coatings on them to reduce bacterial colonization, and you may see those more ever. Research, though, has not shown that the use of antiseptic solutions or antibiotic ointments to the perineal area have reduced the catheter infections from catheters. So you probably are not going to see any type of medication used to kind of prevent that type of problem. Good soap and water, good care, keeping the perineal area clean. If these patients are incontinent of stool, making sure we're cleaning them up as quickly as possible to do those things. Let's move into urethritis. Urethritis is defined as an inflammation of the urethra, and causes are very similar to urinary tract infection. It can be typically bacterial, but also can be chemical in nature. With men, they tend to present with burning or difficulty urinating and a discharge from the urethral meatus. The most common cause of urethritis in men are sexually transmitted diseases. This usually includes gonorrhea or a gram-negative bacterium called uroplasma. Chlamydia also can cause this type of problem as well as trichomonas. Treatment, of course, is going to be determining the source of the urethritis and then treating with a proper antibiotic. To diagnose it, typically a urine culture sensitivity and a urethral swab are going to be taken. In women, urine CNS, not as much a urethral swab in women, but may do a pelvic exam to really make sure there's nothing going on as far as the vaginal region as well. For women, urethritis causes similar manifestations as it does with cystitis. Urethritis tends to be more common in postmenopausal women and appears to be caused by tissue changes related to low estrogen. For these women, starting them on vaginal estrogen cream 3 times a week, many times will take care of that issue. The other thing we see in women presenting with urethritis has to do with chemicals. Bubble baths are notorious for causing urethritis, just a chemical urethritis. Also, feminine products that have fragrance in them many times will cause the urethritis type issue, especially as ladies get older and wearing pads to protect from urinary lossage. Those can tend to cause urethritis as well. So prevention is very important. Don't see as much urethritis as we do cystitis, but it is something you may see. As we look at the urinary tract infectious disorders, pyelonephritis is one that we really are more concerned about. Pyelonephritis is a bacterial infection of the kidney and the renal pelvis. And this bacterial infection, if it becomes chronic and repeated, can lead to end-stage or chronic changes in the kidney and loss of kidney function. Acute is the active bacterial infection of the renal pelvis, where chronic is described from the results of chronic and from repeated or continual upper urinary tract infections or the effects of such infections. Acute pyelonephritis is the most common process. Organism moves up from the urinary tract into the kidney tissue, leading to acute tissue inflammation causing tubular necrosis. You can also get abscesses that form as part of this infection. As those abscesses forms, you begin to get more tissue damage, get damaged tissue, scar tissue building up, and loss of function of the kidneys. We see approximately 250,000 cases per year of acute pyelonephritis, leading up to about 100,000 hospitalizations. Chronic pyelonephritis occurs with urinary tract defects, obstructions, or most commonly when the urine refluxes from the bladder back into the ureters. The vesico-urethral junction is the point in which the ureters join the bladder, and reflux is kind of that reverse or upward flow of urine toward the renal pelvis and kidney. So if we've got colonization, as we talked about earlier, from the lower urinary tract, it may not be causing any lower urinary tract, but if you get that reflux back up into the kidney area, it can set off an infectious process in the kidneys. Again, the more frequent that the patient has these types of infections, the more damage is caused to the kidneys. Some risk factors for acute pyelonephritis include manipulation, in other words, putting catheters in, exams of that such, pregnancy, urinary tract obstructions, which can lead to reflux we talked about, congenital malformations of the ureters, the urethras, the bladder, all of those can cause some problems. Urinary tract trauma, urinary calculi, stones causing the backup of urine. Also remember the stones are causing damage to the urethra to go down, which allows more greater chance of infections and those problems. And then diabetes. With diabetes, we get a change in the bladder. We can get, as it goes on, can get basically the bladder will not empty as well, will not contract as well, so we can get stasis of urine in the bladder, which leads to a greater chance of bacteria buildup. Also remember, if the diabetes is not controlled, sugar spills over into the urine, which leads to a greater chance of bacteria growth in that environment. 85% of the infections with pyelonephritis are caused by E. coli. You can remember back as we talked about cystitis, E. coli is the number one for creating cystitis. That bacteria ascends from the lower urinary tract and then moves up through the bladder into the ureters, into that renal pelvis, and into those areas. The infection typically is the renal pelvis and the parenchyma, and from there it spreads into the internal cortex of the kidneys, and there tissue destruction, especially the renal tubules, occurs. Once that destruction has taken place, we have scar formation. The scars formation is not a functioning kidney, so we have lost a portion of the function of our kidneys. Clinical manifestations of acute pyelonephritis come from chart 70-3, include fever and chills, flank or back or loin pain, tenderness at the costovertebral angle, nausea and vomiting, general malaise and fatigue, burning, urgency or frequency of urination, and these patients may have had a recent cystitis or a urinary tract infection. They may not have taken all their medications, might not have been the proper medication, didn't kill all the bacteria. All of that can lead to that acute pyelonephritis. As you talk about patients who have had a kidney transplant, we have to be very diligent with these patients to prevent pyelonephritis. With a kidney transplant, the kidney is placed in the renal pelvis area, so the distance from the kidney to the bladder is very short. So we'll jump on top of any kind of cystitis with these patients because they're at a much greater risk of developing this pyelonephritis. One, because of the distance, and number two, because we keep them immunosuppressed because of that. So you do understand, if we have someone with a kidney transplant, we must take great precautions if they get a cystitis. And once they get pyelonephritis, then it really becomes a very, should I say, dire situation, such that we're treating them with the most powerful antibiotics and trying to prevent any type of kidney damage for those folks. Typical management, though, of these patients with acute pyelonephritis is bed rest until the symptoms subside. We want to make sure we're monitoring their intake and output. If they don't have any other type of problems, such as congestive heart failure, chronic changes in the kidneys where they already have lost a large amount of the function of their kidneys, we want to encourage large fluid intake, enough to maintain the urine output at around 1,500 milliliters per day. If oliguria is present, which is defined as less than 400 milliliters of urine output per day, then we want to put them on a low-protein, high-caloric diet. These patients don't need the protein because of how it's going to clog up the kidneys. We may be seeing some issues with that. Medications, typically antimicrobials. Those are typically going to be given IV so that we can get a level up in a hurry. And these patients may stay on that several days and then go home on oral antibiotics for 14 days or so. Analgesics can be given. Really want to try to avoid using non-steroidal anti-inflammatories, especially if a patient has any type of chronic kidney problems. Non-steroidal anti-inflammatories have been shown to actually hasten renal problems and kill off kidney tissue. So trying to use NSAIDs is something that we don't want to do with these patients. Now, chronic pyelonephritis, basically when we have recurrent acute pyelonephritis, again, because we're seeing these recurrent pyelonephritis, we need to try to look then, are there structural deformities that are causing this? Is there some type of obstruction from stones? Or we see this a lot with our patients who have had spinal cord injuries and have a neurogenic bladder. We'll also look at our patients who have diabetes to make sure they don't have a problem with their bladder as well. Now, chronic pyelonephritis can also, even though we have the recurrent infectious type processes, we also can see a cell-mediated type process going on. So what happens is basically once we get the bacterial antigens in there, we get the immune system going. And these immune systems sometimes will lay down a process that will damage the kidneys. This is much more prevalent as we talk about glomerulonephritis as we go along. And chronic pyelonephritis can also be caused by an autoimmune process. Those can cause some issues, IgA nephropathy, systemic lupus erythematosus. And then we talked about use of NSAIDs. Chronic use of NSAIDs can cause damage to the kidneys, so we would definitely want to avoid those if at all possible. When we have chronic pyelonephritis, we get inflammation and the fibrosis that leads to the deformity of the renal pelvis and calluses. Repeated or continuous infections create additional scar tissue, which changes the blood vessels, changes the glomerular and tubular structures. As a result, filtration, reabsorption, and secretion are impaired, and kidney function is reduced. So you can see here as kind of chronic continuous microbial invasions in the renal pelvis, leading to the inflammatory process, which results in fibrosis of scar tissue, which leads to decreased tubular reabsorption and secretion and impaired kidney function. Clinical manifestations of chronic pyelonephritis are hypertension, the inability to conserve sodium, decreased ability to concentrate the urine, and nocturia, and a tendency to hyperkalemia and acidosis. The inability to conserve sodium, in other words, we're losing sodium through the kidneys, and if you think about where sodium goes, so does water. So basically, as we're losing that sodium, and water is going along with it, so urine's going to be less concentrated. Because the urine's less concentrated, that's going to lead to the nocturia. And because we're not conserving sodium, that means we are conserving potassium. Therefore, we can get a hyperkalemia. The acidosis occurs because the body also cannot conserve the bicarb ions. So we're losing bicarb ions in the urine, which leads to a metabolic acidosis for these patients. Management falls into two areas: non-surgical, which is broken down into pharmacological and nutritional, and surgical. Now, management, when we start looking at the non-surgical, pharmacological, basically we want to do pain management for these patients. Again, one of the causes can be stones, and it also, as we get in inflammation and infection up in the kidneys, it can be very painful. Most of the time you're going to see opioid type medications used. We do want to try to avoid the NSAIDs if at all possible. Although your book talks about the use of NSAIDs appropriately, most of the nephrologists I have taught with and worked with basically will say stay away from those at all cost. Broad spectrum antibiotics are used initially, and again, these are typically going to be given IVs so we can get adequate blood levels to that. Antibiotics may be changed once we get the culture and sensitivity back and we identify the organism, and that one of the newer antibiotic might be more might take care of that infection better. So you may see changes in antibiotics as it goes along. Again, you as nurses need to be watching for those culture and sensitivities and making sure that your patient is on the correct antibiotic. Again, with the IV antibiotics, make sure you're giving them on time. Make sure your patients are getting those. Patients may also be given some urinary aseptic drugs, something called macrodatin, for those patients. And nutritional intake has to have adequate calories from all food groups for proper healing to occur. Fluid intake is recommended at 2 liters per day unless other health problems require fluid restrictions. Your patient may have congestive heart failure. So be aware that the fluid intake is based on your patient's other medical problems that go along. Surgical interventions are going to talk about correcting any kind of structural problems that are causing urine reflux or obstruction of urine flow. You may get a pyelithotomy, which is removal of the stone from the kidney. This is needed for large stones and from removal in the renal pelvis and anything that's blocking the flow and causes infections. A urethroplasty is a repair of the ureters or revision of the ureters. Remember, sometimes we get strictures in those, so urethroplasty may have to be done for those patients. A nephrectomy is the last resort when we can't get that infection cleared up in there and we're continuing to have problems. If it looks like these patients are going into, they've had sepsis from this and we just can't get it cleared up, many times they will go ahead and remove the kidney to prevent further problems and so the process can get better. For pyelonephritis, for our patients, teaching as they go home is going to be very important. Make sure they understand what drugs they're taking, the purpose for taking them, the timing, frequent duration, possible side effects, the role of nutrition and adequate fluid intake, the need for balance between rest and activity, and they need to understand what kind of problems they need to come back to the doctor for. And if this is a chronic problem and these patients understand it's chronic, we need to look at their coping mechanisms. How are they coping? What kind of family support do they have? All of those become very important as we're looking at it with these patients. That's the conclusion of pyelonephritis. Have a great day.